My talk is designed on cytomorphometry in platelet disorders. This is the place where I work. This is BLK Super Specialty Hospital, New Delhi. And I bring you warm regards from my department, that is the Department of Hematology, which works in this hospital. Now, without much ado, I would like to go ahead with a few questions. What I'm sure all of you would be facing these kind of questions and clinical scenarios in your daily practice. The first one, 7-year-old girl with PTK, who visited otherwise asymptomatic, a 12-year-old boy with asymptomatic thrombocytopenia, tested somewhere else and came to our hospital. 24-year-old lady with low platelet count was having some menorrhagia symptoms. A 44-year-old man with a platelet count which was given as 4+ on the analyzer and 3+ on the analyzer, and one didn't know what to go ahead and do with it. And a 65-year-old man with variable platelet counts, trying to go and reach any of these places just to get the right platelet counts. 60-year-old post-stem cell transplant, again an unreliable count, and I'm sure all of you would be actually understanding what are the various kinds of scenarios in all of them. Just to give you an example, this is where the scenarios were. So you had the first case, which was an ITP, and the second case, which was a pseudothrombocytopenia, a third case, which was a systemic lupus erythematosus, a fourth case, which was essential thrombocythemia, the other case, which was myelodysplastic syndrome, and lastly, the case where the sample was being taken from the IV lines repeatedly, and that was giving you a wrong count, which was basically a pre-analytical error. So you can yourself imagine the kind of platelets which start getting problems, and you start getting issues with all of these cases. Just to understand how the platelets function in an individual, and I'm sure a lot of you would already know about it, but for the benefit of the postgraduates who will be participating in today's seminar, we all know that the platelet is manufactured within the bone marrow, and in the bone marrow you have this largest cell, which is the megakaryocyte, and from the megakaryocyte obviously you have these larger pseudopodia like stuff which comes out, and these are called your proplatelets, and the proplatelets eventually release these smaller particles in the sinusoids, and this is how the megakaryocyte generally gets incorporated into the sinusoid, and from the sinusoid, from this megakaryocyte, these small little particles get into the sinusoid and get into the circulation. So this is how the platelets are generally seen over there. Now, why do we talk about platelets so much? Why are we so concerned about platelets? Is because a lot of people think just taking a transfusion would be like so simple, but I'm sure people who are actually with transfusion medicine and a lot of other people who have understood the implications of transfusion would understand and realize that there will be people who will have antibody development, which could be both HLA antibody as well as non-HLA antibody. You could also have platelet-specific antibodies. There could be transfusion-transmitted infections, which one could get, including bacterial infections, and of course the allergic reactions, which can happen to many individuals, in such cases. So, therefore, transfusion of platelets is best avoided. Now let's look at platelets in general. Platelet counting, if you look at the platelet disorders in general, you can primarily classify them between congenital and acquired, and within the congenital and acquired compartments, based on the numbers in the function, you can classify them as quantitative and qualitative, and within quantitative they can be either reduced or increased. So that's how the ballpark differentiation of various platelet disorders can be done. If you look at the quantitative thrombocytopenia, quantitative defect, and that too a thrombocytopenia, it is primarily either decreased marrow production of the platelets, or you can have splenic sequestration where there is an increased destruction or accelerated destruction, which happens in, say, for instance, hemolytic uremic syndrome or some other viral infections like dengue, etc., or even bacterial infections. So I'm not sure how many of you would know this. The history of platelet counting dates back to early 1900s, and this is the man who actually gave us this information. If you look at this particular picture, the guy is an Italian pathologist. One second. Yeah. So his name is Aurelio Bizzero. He's an Italian pathologist, and he's the one who actually first described the platelets as distinct corpuscles and gave us the concept of counting the platelets, and also told us about the role in coagulation and thrombosis. Now, when we try to count the platelets, historically, the platelet counting falls into two major groups. If we look at the groups, One is the direct method by hemocytometry, which is a lot of them, and then microscopy, and indirect methods wherein the platelets are counted in proportion to the red cells, and this can happen on a smear, and it can also happen in the analyzer, and we'll see it in my subsequent slides. Previously, when we would do platelet counting, there would be what we called semi-automated methods of counting, and it was like not really the true platelet counts, because they would always try to do platelet counts on a platelet-rich plasma, and obviously the reference ranges would be different. But if you look at the fully automated methods today, you just take the platelet sample and you just run it through the analyzer, and you are able to actually get the platelet counts at the drop of the hat. Now, till in fact 2001, and from 1998, the International Council for Standardization and Hematology gave platelet counting basis on a manual phase contrast microscopy, and this remained in picture for a very, very long time. However, it was soon realized that this has its own fallacies and therefore is not a reliable methodology of counting. And in 2001, the International Council for Standardization in Hematology has changed it from the manual counting on a new bus chamber to a flow cytometric platelet counting method using the RBC platelet ratio. And in this, two antibodies which are predominantly used are CD41 and 61 to identify the platelets in reference to the red blood cell counts. So this is from one of the articles that I have taken from Carol Briggs, where it's shown on a flow cytometric platform that you take the platelets are the ones which are showing either 61 or 41, and the RBCs which are either expressing glycophorin or 71A, or you're taking them on a forward scatter using the cell size, and basis that you're then counting the platelets vis-a-vis the RBCs. You are expected to avoid the platelet RBC coincidences which can happen in flow cytometry, and then basis this you give it basis on a formula. Now, when we look at platelet counting today, there are many automated platelet counting methodologies which are based, a lot of them are based on impedance. Some of them are based on optical methodologies. Some of them are also based on impedance optical methodologies, and a lot of them talk about immunological methodologies as well. I will not get into details of all of them, but we need to remember that the counting platelets today is become much better than what we were, but the quest is still ongoing. Just to give you an idea about how the entire platelet concept counting in a hematology analysis comes about, it is important to realize that when the blood is aspirated into a hematology analyzer, it's actually divided into two major portions. One which goes into the RBC platelet channel and the other one which goes into the WBC channel. We'll not get into the WBC part of it, but let's remember that it goes into the RBC channel, and from the RBC channel, you are actually able to pick up your hemoglobin, you lyse the red cells, and then you start counting the platelets as well. And you are also able to take various other platelet parameters, which include the platelet pulses as well as the red pulses, and basis that you're able to give your impedance-based counting. Of course, it's the same process which is then followed, and it's taken into what is called the optical or the fluorescence channel, and from there you're getting other parameters as well. Now, why are we so much concerned about RBC and platelet count together is because, if you remember, they are all coming together from the RBC and the platelet channel, and because they're coming together, they have a problem of affecting each other. The reason is that their counting is in the impedance channel is primarily based on the cell size. So it doesn't really know that it's a platelet or it's an RBC. It only arbitrarily distinguishes between them basis the size of the cell. Now, where is the problem? The problem is that when you have a platelet count, it is in thousands and lakhs, whereas the RBC count is in millions. It's equivalent to something like a bucket of water going into a sea versus a sea going into a bucket of water. So obviously, the RBC counts, when they are much higher and they are also smaller in size, like for instance in fragmented RBCs or severely hypochromic microcytes, they are more likely to affect your platelet count than vice versa, because again, the counts are much lesser compared to the RBC count. And that's what is very, very important to be kept in mind when you're looking at hematology analyzers. So this is where the issue with the impedance platelet counting starts. You have the RBCs, which can interfere in the platelet, and the platelets, of course, can also interfere in the RBC area. So therefore, whenever you will have large platelets or platelet clumps, they will come into this area and give you problems while counting. And that's what the analyzer is able to pick them out as well. So to take care of this, you have what is called the optical or the fluorescence platelet counting, and we will see how all those parameters will give you some information subsequently as we go through the slides. Now, platelet counting, if we look at it, it's a man versus a machine kind of a concept. And I would really want to remove the term versus, because it's man who's getting assisted by the machine. Sorry. So if you look at it, you have the impedance counting, which was based on these different analyzers. Of course, you also have optical methodologies, and now majority of the analyzers, including the analyzers from Mindray, include the impedance and the optics together. But for the morphologist and me and many others who might be attending this particular meeting, we would still prefer to use a peripheral smear on a microscope and give the platelet counting, with a lot of issues which are there with counting on the peripheral smears. So now if we look at the platelet parameters which are coming out from various analyzers, they are very useful parameters which are coming from the analyzers, and these platelet parameters are actually extremely useful in differentiating various types of diseases. One of the very important parameters which a lot of us primarily ignore is the mean platelet volume. And if you look at various disease states where mean platelet volume is associated with various disease states, there are numerous publications to this effect. And if you see, it's the most common ones which are involved is the cardiac ailment as well as the neurological ailment. So whenever you have thrombosis or thrombotic episodes which are leading to, say, myocardial infarctions, anginas, as well as the ones which are affecting the brain, like the strokes, platelets do have a very important role. And for those of you who would have attended Dr. Nair's presentation, you would have realized platelet happens to be one of the most pivotal cells in the entire coagulation cascade. We also need to remember that mean platelet volume, the moment the mean platelet volume decreases, that also starts giving you some information with respect to the disease state that you might be dealing with. Of course, there is a plethora of investigations, which is a plethora of, sorry, not the investigations, but the publications which are there in literature, which talks about how the mean platelet volume is associated with various disease states. I will not really advocate that that's really true or not true, but what I would definitely say is that there are conditions where MPV becomes an important risk factor, and that includes the arterial thrombosis, the acute myocardial infarction, diabetics with all these high risk possibilities of having MI or arterial thrombosis, and of course the venous thromboembolism. Now, perhaps one of the most important and the most interesting examples where the mean platelet volume plays an extremely important role, and if we would not really have the analyzer in front of us to give us the mean platelet volume, it might be very difficult for us to actually calculate the mean platelet volume, which is so low. So you have this child which has got this eczematous rash, the rash on the back, as well as these small little tiny platelets which are there on the platelet, on the smear. And this is a typical case of what is called the Wiskott-Aldrich syndrome, or the WAS. And it is one of the indications where mean platelet volume plays an extremely important role for detection. So if you look at mean platelet volume in various other disease states, for example, one of the diseases which we grapple with almost every year is dengue. And there is this study which has come out from Tamil Nadu itself. I'm sorry, I don't remember the author here, but the mean platelet volume has been taken as one of the important parameters to determine how dengue would behave. So if you have a high mean platelet volume and it's stable platelet counts, it indicates recovery from the disease and no transfusions is required. Whereas if you have a high mean platelet volume and falling platelets, it indicates active disease, and therefore in such cases transfusions might be needed. Again, when you have a low mean platelet volume with a low platelet count, it also indicates hemorrhagic tendency and therefore a possible need for platelet transfusion. So when we look at this entire scenario, mean platelet volume has a very significant role to play, and one should keep that in mind. You would also need to remember that mean platelet volume has many influencing factors on itself. So it includes lots of genetic variations, age, of course, the gender also, race. All these have a very important role to play. But remember, it's also a very important inflammatory marker, and therefore many other parameters might affect it as well, and also the hormones, etc. The other interesting parameter which a lot of people talk about is the immature platelet fraction. And in fact, it had become such a big rage with many hospitals and many scientists and many pathologists, in fact, wanting to take the credit of discovering this new interesting parameter. Some of them did do that as well. Just to give you one of the examples, this is a blood donor from the East Indian origin. If you look at the impedance platelet count of this particular patient donor, the platelet count was low, and invariably such people would be dissuaded from donating, for the platelet harvesting. But in this particular case, when an optical platelet count was done, the platelet count was much higher at 162, and therefore was eligible to become a donor. I also like to show this picture in majority of my presentations whenever I talk about immature platelet fraction, for the simple fact that this particular advertisement makes you remember so much about immature platelet fraction, because IPF, when you didn't have it, you were always envying the people who had it. And now fortunately we have it as well, so I think a lot of people do envy us. But immature platelet fraction is here to stay, and it helps you a lot in gives you a lot of information. So what is immature platelet fraction? It's nothing but a fraction of the platelets which is larger in size. So what you are doing is you are taking the size versus the fluorescence, and this particular portion of the platelets which is having a larger size and the larger fluorescence, more fluorescence or higher fluorescence, is the one which is taken as the fraction and is expressed as a percentage. So the higher the percentage of immature platelet fraction, the possibility of functionality of the marrow is obviously better. It is something what you do for a retic count. So if you look at immature platelet fraction, pathogenesis of low platelet count, high IPF always suggests an active bone marrow, whereas a low IPF will suggest a depressed bone marrow. In fact, in our center, because we do a large number of bone marrow transplants, we have also observed that IPF is one of the first indicators of bone marrow regeneration, something which has also been published by many other people in bone marrow transplantation fraternity across the globe. You need to develop your reference intervals for this. Obviously, there is a difference between various analyzers when you're looking at the IPF. The reference interval which we have derived at our place is 0.6 to 8%, and basis that we are able to take our calls. Now, let me give you an example of a very interesting and a landmark study, which was actually done by my colleague, Dr. Tina, and her colleagues at Hinduja Hospital in Mumbai, where they looked at dengue positive patients and looked at the IPF percentages, and eventually came out with a very beautiful paper, which got eventually published in the International Journal of Laboratory Hematology. All they did was they ensured that they did the platelet counts and the IPF within 6 hours of receiving the sample, because there are otherwise various variabilities which can come up in the IPF as well. This is what the publication was done in 2013, IPF as an indicator of platelet recovery in dengue. And just to give you an idea how it works, I'll just show you the slide from her presentation, wherein if you look at the platelet counts, which are in blue, as the platelet count keeps dropping, the IPF in the purple keeps increasing. And at certain point of time, the IPF starts becoming stable, and that's the point when the platelets start coming up. So basis this, it was a predictable variable or a predictable value basis which it was possible for us to determine when the platelets are going to be recovering. And therefore, if you look at this particular study, it was in fact a very interesting study, because it gave you a possibility of restricting transfusions in patients with dengue. In fact, for this purpose, it was recognized across the globe by 3 major societies and awarded as well. Now, they also came up with interesting information where they said that IPF is a potential tool for predicting platelet recovery in dengue patients. And they also gave a value of 10% as an indicator of platelet recovery in next 24 to 48 hours, which was eventually actually proved that it is not right. So all in all, what I would say is that the moment you're monitoring a patient of dengue with IPF, if your IPF values become stable for 2 consecutive values on 2 consecutive days, you need not transfuse the patient, and the patient is likely to recover in the next 24 to 48 hours. There is another parameter which is called platelet to large cell ratio. A lot of people don't even know about it, forget about using it, but this is a very interesting parameter. Again, the platelet to large cell ratio is the ratio of the platelets, is the amount of platelets which are seen at 20 femtoliters and beyond on the platelet distribution width. And this platelet to large cell ratio has been shown to be correlating very strongly with the coronary artery disease. And therefore, if P-LCR values are taken and eventually looked at, you might be able to give this information to a lot of people as well. In fact, platelet to large cell ratio, IPF values, neutrophil to lymphocyte ratio, and a few other parameters on the CBC analyzers have already been proven very significantly to be useful, especially in today's day and age with the COVID-19 patients. There is also a very interesting index which is called the composite platelet index. It's a conceptual index which is derived by multiplying the platelet count with the mean platelet volume, and this has also been shown to be strongly associated with the coronary artery disease and the thrombotic episodes. We must remember that these various indices which are there, the mean platelet volume, the platelet distribution width in femtoliters and percentages, platelet crit equivalent of hematocrit, immature platelet fraction, and the platelet large cell ratio needs to have its own reference intervals. You need to set it up in your own laboratories, and then basis this, you are able to differentiate between various disease states. So my talk would never be complete if I do not talk about the congenital thrombocytopenias. Of course, the number of congenital thrombocytopenias which we deal in our laboratories in usual practice is pretty limited. However, people who are actually dealing with a pediatric kind of or a childcare kind of a hospital, they will be dealing with it much more often. We need to remember this congenital disorders were first discovered way back in 1735, and of course, the number of people who came into the picture and eventually gave us a lot of information, not only about their identification, but also about their therapy using thrombopoietin mimetics, has actually improved the lifestyle and the possible morbidity because of congenital thrombocytopenic disorders. I would consider myself relatively lucky because I had to just remember these few, the congenital syndromes, and amongst them also the ones which would actually come in my exams would primarily be either Bernard-Sawyer or Glanzmann's thrombasthenia. And then you would also need to know a little bit about Wiskott-Aldrich and one of these syndromes which are there, the TAR syndromes, etc. But just imagine the number of syndromes which have come up in last almost 10 to 15 years, and most of them have actually some associated abnormality, mutational abnormality along with it. And these are the ones which are actually becoming more and more difficult, first to identify and then to eventually even treat. So if you look at the evolving new inherited thrombocytopenias, this is where we were in 2000s when I had just started my post-graduation, to a time where the number of, congenital thrombocytopenic syndromes have increased markedly. Now, fortunately for us, a lot of these are actually dependent upon the platelet size parameters, and therefore, basis this, we are able to actually differentiate between various types of mutations if we are able to identify the various cell sizes. So if you look at the mean platelet volumes, mean platelet distribution, platelet to large cell ratios, and the platelet to small cell ratios, you are actually able to differentiate between most of these disorders and then do a specific mutation for them and get to know what you're dealing with. Just to give you an idea, if you look at the disorders vis-a-vis the mean platelet diameters, this is the MPD, is a mean platelet diameter here. So basis the mean platelet diameter and the platelet to large cell ratio, you're actually able to classify and subgroup all of these disorders, and that is how it is going to give you a much further information when you're trying to take it from a hematology analyzer. In addition to all this, we also need to understand that all of these parameters will need to have specific cutoffs. A lot of people have developed their own cutoffs for this, and we need to have this identified in our own centers. We are trying to do a study on this in our center as well, and hopefully, in due course of time, should be able to share the data with you all. So if I look at steps for interpreting the platelet portion of the complete blood counts today, we need to identify the total platelet count relative to the reference interval. We need to examine the mean platelet volume, the platelet distribution width. We should try and identify disease states based on the histogram. We can also have an algorithmic approach of identifying the platelet counts accurately, and then also examine IPF, correlate numerical parameters with the platelet morphology, and correlate with RBC and the WBC parameters in any patient for that matter, to know what we are dealing with. With that, I would like to thank you all for your kind attention. I hope you all will probably move into doing cytomorphometry of platelets far more aggressively on the analyzer than what we are doing so far. I'd be happy to answer any questions if there are. Thank you very much.
Thank you, sir. It was really an eye-opener session only. Many things which we learned, certain things we were able to learn from your session, and the importance of IPF and platelet morphometry in dengue and other cases. So it was really good one listening to you. Thank you very much.
Thank you.
If there are any questions, one second.
Well, I can just read one question which is here, which talks about does the anticoagulant affect the mean platelet volume or the IPF values?
Yes.
The answer to that is absolutely yes. Especially it is the time duration which is far more important. So if you're taking a platelet, if you're taking a sample which is in regular routine K2 or K3 EDTA, they are affected only after about 6 hours. This is the study which has been done by Dr. Tina et al. In Hinduja Hospital also. And we have also replicated the study in our center. There is also a study to this effect by Dr. Pradeep Suri from his center, which is all these studies are already published, where it has been mentioned. There is also another study from Bangalore I forget the name of the author, but it is from the lab of Dr. Prasad, Dr. Sujay Prasad, the Anand labs. So all these places, yes, everybody has proven beyond doubt that anticoagulants do have an effect. You are expected to take the sample only in EDTA and not in citrate or any other anticoagulants, because the IPF values from there as well as the MPV values are slightly different. If you want to follow those values, then you will have to set up your own reference intervals for all of that. And also the time duration is extremely important. So if you do not keep the time duration of 6 hours intact, then the reliability of these values will become questionable. There is another question which talks about, you've not mentioned platelet count on Newbar's chamber. Well, I did mention about it because that was the reference method by the ICSH in 1988. And from 1988 till 2001, it continued to remain as the reference method. However, from 2001 onwards, the reference method by ICSH now is a flow cytometry based methodology, which is between the RBCs and the platelet increment ratios. That's what is taken into account. And however, I know it is practically not possible for everyone to do flow cytometry for platelet counting. So therefore, having that as a reference method is only for the fact that you will be able to get the best possible counting from the analyzer. The other aspect which I did not deliberately touch upon was the manual platelet count on a smear. The reason why I did not touch it was that I generally do not advocate using smear as the methodology of platelet counts, especially in low platelet counts, because we have not standardized. Most of the people have not standardized. In fact, when I did my post-graduation, the factor which I was told was 20,000. After my PG, when I did my residency, the factor came down to 15,000. And actually today I'm using a factor of 10,000. So you can imagine that the counting has changed from 20,000 to 10,000 in last 15 to 17 years in myself itself, So practically speaking, counting on a smear becomes very difficult because you have to have a very, very good smear, which is like an ideal smear. And then you should also be making sure that it's been prepared appropriately, stained appropriately. And once you've stained it appropriately and then looking at the microscope, you have to ensure that the field of vision is taken into account. Your field of vision might be smaller and the number of platelets might be lesser in that, and therefore the factor might be different. Whereas if a field of vision is larger, then you will have more number of platelets there and the factor might be smaller. So you have to analyze it in your own center. And once you've done that, you can adopt using manual technique on a smear for doing this counting.
The freshness of the sample affect MPV. That also is a question. Anticoagulant effect on MPV or IPF.
So as I mentioned, anticoagulant effect does happen on the MPV as well as on IPF. So if you want to use IPF and MPV, the best anticoagulant to be used is EDTA. And within EDTA, and if you do not want to use EDTA and for whatever reasons you've had samples in other anticoagulants, you will have to validate in your center. What we have observed is that there are relatively higher values of MPV when you use heparin and citrate. So this is our study which we have done in our center. There are other studies to this effect from other places as well globally, which are already published, giving you similar information.
Any algorithm to be followed?
Okay, so the ideal algorithm is still an enigma. Let's be very honest on that. But having said what I said, we need to remember that your analyzer has to be tweaked and customized in such a way that you have put in the rules in the analyzer for review very, very correctly and very, very perfectly. The best way to do that is tweak your rules appropriately vis-a-vis the values on the smear. Once you have done that, you then need to ensure that once you have taken a sample which has been run on the analyzer and it is being flagged by the analyzer, it automatically gets into running into an optical or the fluorescence mode. And post fluorescence mode, whatever counts are there, you will take them as gospel truth unless and until the analyzer itself again tells you that it is not sure of what it's done. Then in that case, there will be a slight review. As a practice in our laboratory, what we have done is whenever there is a first sample which is coming from a patient and there is no delta on that, we will review the smear, especially if the counts are low or counts are high. But if the counts are within the reference interval, we have the rule is that we let it go. But I must give a caveat here. You must keep one thing in mind. Many a times, these small little cell fragments can also interfere in the platelet counting, and you might get an absolutely normal platelet count. So there will be issues. Machine after all is a machine. It's the man who's the most important person behind the machine. You need to set up your algorithm. There are various algorithms available already in International Journal of Laboratory Hematology, which you can follow and validate in your center before you put them into your practice.
Dengue, which parameter is the most important one?
Between IPF and MPV? Okay, so if you look at IPF and MPV, it's a very interesting fight between the two parameters. The reason why I'm saying so is the analyzers which are giving you IPF, uh, these analyzers at very low counts somehow are not able to give you the MPV. I don't know whether you people who are using this have observed this or not, but the fact is that at the very low counts, the MPV parameter somehow has been jeopardized in most of the analyzers who give you IPF. I don't know, maybe deliberately. But then considering IPF as a parameter, it's a very robust parameter, provided you use it within those first 6 hours. So if I have to choose between MPV and IPF, I would prefer an IPF in a setting of dengue. But then if I would was looking at a disease like myeloproliferative disorder, or I was looking at a disease like Wiskott-Aldrich syndrome, then I would probably go ahead with an MPV, because IPF there will not have any significance at all. So it is disease specific. So if you look at it, my talk was also very clearly saying cytomorphometry in platelet disorders. The idea was that you have to take a parameter in consonance with the disease that you're trying to look for. Do not try to just generalize saying IPF is the best and MPV is the worst, or vice versa. Each of these parameters have a value in their respective states and respective disorders.